Very much for that introduction and for taking bits and pieces out of my CV. It's a pleasure to be here. It's a pleasure to be here. I always find it very worthwhile to interact with nurses and try to optimize patient care. I have had the fortune of working with some absolutely outstandingly good nurses in the various places that I have worked in. And I've seen, I think the volume can come down a little bit. I've seen the very best of nursing in organizations of very wide variety of resources, organization and funding. And having worked so long in the clinical field, I've also seen, unfortunately, like true for all of us, some of the very worst of nursing. I've also seen how it is possible to provide fantastic nursing with limited resources. So that's not the main thing which defines the quality of work. With that brief introduction, the topic that we were given is optimizing patient care through effective interaction. When Praveen and I were first approached by Josephine for this meeting, the topic given to us was slightly different. And we were asked to debate whether clinical excellence can be achieved by the nurse or by the physician. And that would have been somewhat of a more funny kind of talk and debate. But I'm glad that we're talking a little more seriously. And on a more serious note, if you're talking of improving patient care, is there need to improve? With all these accreditations and quality indicators and all the things, it's nice to achieve all that, but sometimes one can get carried away and think we're doing a fantastic job. Now, one thing that people who know me and who have worked with me know, I speak in very blunt, black and white things. So we're not doing fantastic. There's plenty of room for improvement. Everywhere. We are not already excellent, and the answer to this question is a very resounding no. Why am I saying such a loud no? This article that I have marked there goes back about 4 or 5 years in time, but it's a very important thing, and anybody who's actually concerned about one of the most important final determinants of whether we are doing good work or not is what we do to a patient when they come to hospital. Do we add to their illness or do they improve them? Unfortunately, the hard truth is, it's very common that a patient, not very common, but too common to be acceptable, that a patient who comes in, for example, for a cardiac cath gets septicemia, or somebody who comes in with a stroke gets ventilator-associated pneumonia. These things are not uncommon. They are entirely avoidable. And these are a good indicator of whether we are actually doing good work or not. So are we doing good work? The answer is very shameful. We are the world's worst country in antibiotic abuse. We are the world's worst country in antibiotic abuse. And all of us tend to think it's not my fault. And to make it worse, the biggest culprits in this crime are the private corporate hospitals. Most government hospitals do not have the resources to use fancy antibiotics. Corporate hospitals do. And we think that stronger the antibiotic, better I look after the patient. Most of us know what I'm talking about. I just want to highlight and make a point. We refuse to recognize that this battle cannot be won by stronger antibiotics. This can only be won by better practices. Something else to put us where we belong, to tell us how good we really are. This is WHO ranking of healthcare. Out of 177 countries which are ranked, we are 112. Bangladesh is better than us. Sri Lanka is much better than us. And this is nothing to do with healthcare resources, GDP per capita, how much is being spent, because Oman can be 8th in the world, UK can be 18th, and USA can be 37th. We are 112th. So my original question, do we need to improve? Of course we need to improve. The first thing in improving is to acknowledge that I'm doing something wrong. If we keep believing we are doing something fantastic, it's very difficult to motivate each and one of us to improve. Is everything very bad? No. There are pockets of excellence. But even the best among us, there's a clear scope for improvement. And the first thing that I want this audience to go away going by is there is a clear and urgent need to identify areas that we can improve and then work towards improving. To get a little more specific, how can nurses help in this? think of yourself as equal partners. This is not just words, and I've seen the best of this. An example that I'll go back to is before NHS in the UK became what it is now, which is not very good. NHS used to be a fantastic way of delivering good patient care. Nothing is perfect, but NHS was close to perfect. One of the things that struck me first when I went to England in the 1980s, and this applies to all of us. See, the doctor gets to decide how to treat the patient, to say this is the patient's requirement, this is the treatment we're going to give. But the person or the team that actually delivers it is the nursing staff. And therefore, in the ward, the nurse is the boss. The hospital has to recognize this. Good hospitals work like that. In the ward, nurse is the boss. Even if the senior most consultant wants to do something in the ward, you need to do it in cooperation and in consultation, and if it comes to that, with the permission of the ward nurse in charge. This is the best way to deliver good patient care. Unfortunately, our culture is a little different. We like to believe in bosses, and boss cannot be questioned and stuff like that, and there are all kinds of misconceptions. That's not the best way of working. So nurses are equal partners. You need to know your strengths. If there are partners, all partners don't have the same strength. They're not equally good at different things. So you're equal to anybody else. I say this to my younger friends, and you are equal to anybody else. You are an important part of this whole team. You don't have to listen. Nobody is your boss. I'm not saying this to disrupt the hierarchy and discipline, but you are equal to anybody else. You have to believe that in your heart. You have to know your strengths. And this last thing is for the senior management and senior nursing. You have to recognize and reward good nursing. Good nursing is more important than good record keeping. I'll come to that towards the end of my talk. That is certain thing, the nurse is the boss. And you reward good nursing, that is more important than good record keeping. What does equal partner mean? I already said that you have to divide your responsibilities. Certain areas the nurse has to take the lead, certain areas the doctor has to take the lead. And the nurse must think of her or his, most nurses are women, but nurse must think of her or his role is which is the best way I can help look after the patient rather than just follow doctor's orders. This is a very common mistake now. There are some orders, you follow the orders, you think your job is well done. If you think you can do something beyond the order, you must have the confidence and the ability, and the doctor must be approachable enough to say, can't we do this better? Some of the best nurses, when we were training as registrars, you get a call from some senior ward nurse, I think so-and-so is not very well, do you want to come and see? It means you better go and see that patient. The nurse must have that role. Nurses and doctors work in a partnership, any partnership. It works best when we recognize and capitalize on each other's strengths and work together. In any teamwork, we need to clearly define the role, not have confusion about who's responsible for what, and work towards clearly stated outcomes. We must know what our goal is. I mentioned you need to know your strengths. What are nurses' strengths? Everywhere, I've worked in many countries, in many different types of organizations. Everywhere, by and large, nurses are very hardworking, they're very sincere, and they follow strict discipline. Nurses follow rules better than doctors. Why? Because nurses believe that the given rule is the best way of getting the job done. Sometimes this is oversimplification, but it's also their strength. You make a set of rules, nurses will follow it. You make a set of rules, doctors will do all kinds of things with it. Because doctors often go beyond the rule. Sometimes that works for the better, but sometimes it can be detrimental also. So these are nurses' strengths. What is the nurse's role in optimizing patient care? Crimean War, somewhere in the north of Turkey, between Imperial Russia and Victorian Britain, little more than 150 years ago. Very bloody war, very bloody war. The very first clinical audit was carried out during that war. Now, clinical audit is one of the pillars of quality control, improvement, etc., right? Very first clinical audit, Crimean War, 150 years ago. As a result of that audit, battlefield injury was reduced and mortality came down from 40%. That means 2 out of 5 soldiers who got injured in that battle used to die before this audit. 2 out of 5, sorry. And only 1 out of 50 died after this audit. So it's a fantastic achievement. So this is the prime example of a nurse recognizing her strengths, defining her role, saying I can improve things, and making the rest of the world sit up and take notice. And what did she do? She just collected data. She analyzed it, she thought about it, got a team together and said, this is it, that's all you need to do. If you do like this, if you avoid infections, you bring down mortality from 40% to 2%. Good nurses, therefore, as I have shown you, have their professional skills, personality traits, and attributes. You need to know the specific areas that you can help in. What are the areas that nurses can take the lead in? And this is just my thoughts over the past couple of days as I put these slides together. But I think many of you will agree, these are important things. So these are areas that nurses can help in, and I will show how you can help in very simple ways, provided you have the support of the people who take decisions in the organization. You don't need many fancy things. Nurses can help in proper hand hygiene. They can help in taking proper, these are all very important areas for good patient care. They can help in drug chart, better use of safe drug charting. And as I said, I'll come back to this towards the end of the talk, nurses can take the lead in ensuring that good nursing takes precedence over good record keeping. What about hand hygiene? Excuse me. People who have managed to practice it and get good results are a few small countries in Northwest Europe. That's related to their bed occupancy rates being slightly lower than full. Everybody knows the theory, everybody tries it. The only way, and I've seen this work, the only way hand hygiene will be utilized effectively and safely if every nurse, even the junior most nurse in the hospital, has full authority, backed fully by hospital administration every single time without any exception or any inquiry. Nurse has to have the authority to do this, is to remind any doctor in the hospital and stop the procedure if necessary if the doctor is not doing hand hygiene. This is the only way it will work. It will never work otherwise. The poor nurse, junior nurse in the ward cannot do this unless she has full backing from hospital administration and senior nursing staff. There's no shortcut to this, all right? And the doctors need to have enough self-respect to honor and respect this discipline. Now, this is very difficult in our culture, as I said in the beginning, but this is the only way of doing it. It can be done. I've seen it being done. It needs full support of hospital administration and senior nursing staff. For every little girl to believe this is the right thing, no matter who it is, if they're not doing it, I'll stop it. What about taking consent? Should never ever be done by the nurse. It makes no sense. And there's no question that the doctor is busy or something or the other. You have to adjust your work and do it properly. It's never ever to be done by a nurse. Needs to be taken by the particular doctor who's doing the procedure or their designated assistant, not by anybody else. Again, this is things that we know, but what happens? Some nurse will write the consent form, write the wrong name of the operation, write whatever. She'll try to do her best. It's not her job, and the hospital administration should put a stop to it. It's a doctor's job. Just a formality, it's a waste of time, it's a waste of paper. It has to be done on the ward with enough time for doctor to explain in a responsible way. And the nurse, when the doctor is doing rounds or whatever, can say, you get different ways of dealing with it. It has to be done. You can't shift the patient out of the ward till it has. There are various ways of doing it, but there's a very important role for the nurse to make sure that you get good patient care. What about drug chart? Again, just like I said in the beginning, every nurse needs to have full authority backed by everybody responsible to insist that orders are written only by doctors, always in capital letters, using generic names always. If you prefer a specific brand, put it in brackets. And it has to be signed and initialed in a recognizable, legible manner. Not some scratch and you don't know who wrote the order is wrong, some mistake happens. These are simple things that any nurse in any hospital can do if she has sufficient backing from seniors. And it will make a tremendous difference in the quality of patient care. And again, if the order is not written like that, the nurse needs to be backed by administration in refusing to carry out the order. And doctors need to have some self-respect and respect this discipline. If a doctor shouts at a nurse for this reason, hospital needs to take appropriate action. That's the only way it will work. All right? Now, a lot of people are nodding in the audience. I don't know how many people will be able to go back and practice this, but this is the only way of doing it. There's no other way of doing it. Now, coming towards the end of my talk to all of you, of course, we all know good record keeping is important. Good record keeping was a very important part of good medical practice and good nursing practice long before these organizations came and long before these laws were laid down. Good record keeping is very important. But it can never ever take precedence over good patient care. Need to be very clear about that. I'll spend a few minutes explaining this. In the past 30 years, to use quality of record keeping, whether your forms are filled, your boxes are ticked, you use that as a surrogate marker for quality of patient care. What do I mean by surrogate marker? It's very difficult to actually measure whether you're giving good care to the patient. So the organization works on the principle that if the correct form has been filled, the boxes have been ticked, it must be that the patient got correct care. But there's a big fallacy in that logic. Now, administrators and senior people need to understand this, that filling the form is not most important. Looking after the patient is more important. Filling the form is done because it is easier to measure whether the form got filled or not. Very difficult to measure whether the patient got good care or not. But this distinction that filling the form is not equal to good care is very, very important for all people who take administrative decisions. And as I said, it's much easier to measure the quality of record keeping than to measure the quality of care. So the focus has shifted across the world into record keeping instead of actually doing what the patient needs. Everywhere that I have worked, in all countries, in all cultures, different parts of the world, most nurses work very hard. They try their best to do both, to do good nursing as well as good record keeping. But there's been an absolute explosion in the amount of paperwork required. There are studies which show that in the West, 1/3 of the doctor's time, and I'm sure this applies equally or more to nurses, 1/3 of the time is used doing non-productive work, doing paperwork. This is absolute waste of everybody's time and resources. We can't escape this because medical practice has become manager-driven, not clinician-driven. So they need ways of measuring whether you're doing your work or not. So some paperwork will be there. It's an evil that we have to live with. And because it's much easier to spot if somebody forgot to fill a form, and unfortunately in our culture it often leads to punishment of some poor girl, clinical care invariably gets compromised for the sake of paperwork. I've seen this across the world in many different types of hospitals, in different organizations. Clinical work gets compromised for the sake of paperwork. A kind of dichotomy between doing the paperwork and doing the clinical work. You need to recognize and make sure that all the people who actually look after patients understand that as long as they're trying their best, that's a key thing. As long as the nurse is trying her best, if there's a lapse in paperwork, it is less important than a lapse in patient care. Patient care is more important than paperwork. I think that's my final message. Thank you.